thanks a lot for that. And I've been hearing this conference for last 2 days now, and you have selected the topics very nicely, and it's been very informative. Now it's my pleasant duty to to introduce the first speaker, who is Dr. Samuel Seidu. He is currently the head of the research for primary care diabetes Europe, and is also the chair of PCDE study group, European Association for the Study of Diabetes at the ESAD. He is an NIHR clinical lecturer at the University of Leicester. His current research interest is on implementation. I think that part is getting cut, but I have read his biodata. He is interested into demystifying the therapeutic inertia, basically, and he's trying to do it at community level for seeing how people can adhere more to medications and lifestyle changes in his area. He's a faculty member of the Primary Care Academic Diabetes Specialist in the UK, board member of the Primary Care Diabetes Society of UK, currently a clinical lead and mentor for diabetes in Leicester. So he will be speaking on changing paradigm to the early sustained glycemic control to prevent complications. I invite Dr. Samuel Seidu to kindly present his talk.
Thank you very much. Thank you for having me. It's always a pleasure to do these meetings. It's my third time speaking in these meetings, and every time I come, I really enjoy the group. I thank Banchi for inviting me once again. Here are my disclosures. Right, so the learning objectives of my session will be to justify early combination treatment in patients with type 2 diabetes. And after talking about the justification, I will spend a bit of time talking about the various phenotypes of type 2 diabetes and how to combine different medications very early on in the disease trajectory in the various subtypes of type 2 diabetes. So as you would see, this is a shift change from what we've been hearing so far, which has been so much detailed science, diabetes, and everything else that we've had so far. The reality is that when you talk about type 2 diabetes, about 90% of the management in most parts of the world is done in the community level and in primary care settings. And diabetologists would only get to see the very complicated cases of diabetes. Within the community or primary care setting, where you are the vast majority of patients, you do need to educate people to take it very seriously and treat aggressively with early combination therapy. At the moment, that is not what is being done. So this is a paper that we published in our unit looking at the issue of therapeutic inertia. And it's a big problem across various countries across the world. And as you can see, for the vast majority of patients, we're just waiting too long for A1Cs above 7%. You're talking about nearly 3 years before of monotherapy before anything else is added. And if you're talking about dual therapy for people with A1C over 7%, sometimes you wait in median of 7.2 years before you get anything added. And similarly, for if you go to a higher target of 7.5, for dual therapy it's about 7.2. And for monotherapy is 2 years, and so on and so forth. And for all the targets, the various targets, you're talking about, A1C levels being left at very high ranges before we do anything. And this has consequences. In a study we published again about 3 years ago from the Leicester Diabetes Center, looking at the UK primary care database, looked at patients who are newly diagnosed type 2 diabetes, over 103,000 patients. And we'll split them into two groups. The first group are those who were intensively treated with A1Cs below 7% within 12 months of diagnosis. And you compare them to those whose A1Cs were not controlled below 7% within 12 months of diagnosis. Follow the two groups up for 5.3 years. And at the end of 5.3 years, what you find is a significantly increased risk of myocardial infarction, about 67%, stroke by 51%, heart failure by 64%, and a composite cardiovascular event of 62%. And what we say is this difference between the very well controlled and the poorly controlled within 12 months, this glycemic legacy, which is driving all the complications. So we do not want to, delay too long before intensifying treatment. So at the moment, this is what we do. You diagnose your patients with type 2 diabetes, they get lifestyle and diet, you get your A1C down after a few months, and then it goes up again, and so you add your metformin monotherapy, and then your A1C comes down again if they're adherent, but then it goes up again with time. So this seesaw approach is not just because the patients are failing, it's not just because the clinicians are not titrating hard enough, it's also because of beta cell failure. As we know from UK PDS, every year after diagnosis, you lose about 4% of beta cell mass. Okay, so there are a lot of physiological reasons as well, in addition to therapeutic inertia. So because of that, what we are advocating is to avoid this seesaw approach at a very high baseline from the outset. What we're advising you to do is to go hard enough and control this A1C much lower with initial combination therapy and keep it as low as possible for as long as possible. And if you do that, you avoid those complications that I talked about in the previous slides. So one way of demonstrating this is, we published this last year in Diabetes Care. And what we are advocating is, if you look at the way UK PDS was recruited, patients who were early in their disease trajectory were intensively treated. Now, if you keep that A1C down for as long as possible, smoothly like that, initially you get microvascular complications here. And as the years come on, you get your macrovascular benefits as well. We are advocating that it's not just a question of getting this A1C down quickly and smoothly for as long as possible. Try to avoid the fluctuation that I described earlier on. That fluctuation above a high A1C baseline is also associated with higher cardiovascular risk, and you don't want to do that. So early combination therapy is one suggestion that we can implement to avoid the seesaw approach at a very high baseline. And it's not a new phenomenon. It's been going on for the past few years, but we are so very much stuck onto old ways of doing waiting to fail approach in various guidelines across the world. This is a systematic review that was published about 7 years ago, looking at 15 randomized controlled trials with a patient population of over 6,693 patients. And they looked at studies that looked at combination therapy with metformin versus a stepwise approach. And what they found was that there was a statistically significant weighted mean difference in A1C in the combined combination therapy compared to the stepwise approach. And more recently, as you know, there was the publication of a Verify trial, which combined vildagliptin with metformin. And as you know from the Verify study, the early combination therapy with metformin and vildagliptin was associated with delayed treatment escalation in newly diagnosed patients. And very recently, again, there was subgroup analysis of that in young type 2 patients who normally we would classify as those that you really need to be very aggressive in their disease trajectory, because patients with young type 2s have a very aggressive disease. And in this subgroup analysis from Verify, again, they were able to show that there was reduced time to treatment failure if you do the early combination therapy with metformin and vildagliptin. The EDIC trial led by Radifronzo has been going on about early combination therapy for a long time, but we haven't been listening. But I think we should start listening. This study, what they looked at was metformin plus pioglitazone and exenatide combined at very early in the disease trajectory, targeting A1C to below 6.5, and anything above 6.5 during the treatment period was regarded as treatment failure. So early combination therapy with a triple therapy was compared to stepwise treatment. And what they found was that the early combination therapy was associated with reduced level of treatment failure and complications, and indeed less side effects. There were less hypoglycemia in the combination therapy compared to the stepwise approach. So based on all this data, what we are advocating in primary care diabetes Europe is to consider early combination therapy to tackle this problem with therapeutic inertia that we have in primary care. And earlier this year, we published 2 papers, consensus reports on this topic. The first was published in Primary Care Diabetes Europe Journal, and the other was also published in the IDF journal, Diabetes Research and Clinical Practice. So what exactly do we recommend? So like most other guidelines, what we have suggested is before you manage your patient with type 2 diabetes, you need to categorize them in various subgroups. So you know the disease burden, cardiovascular disease burden for the various subgroups. And so to simplify the various phenotypes in type 2 diabetes in primary care, we suggest that patients who have established cardiovascular disease, those with multiple cardiovascular risk factors like hypertension, hyperlipidemia, obesity, smoking, and physical inactivity, those with eGFR less than 60, and those with albuminuria more than 30 per day, 30 milligrams per day, and those who are younger than 40, these patients should be classed as very high risk of cardiovascular disease. Every other patient can be considered as being at high risk of cardiovascular disease. We don't believe that anybody with type 2 diabetes should be at moderate risk or mild risk. They are either very high risk, as in this group, or high risk. And this is a schematic representation. Those with established cardiovascular disease, ASCVD, heart failure, CKD, and those under 40s, they are at very high risk of cardiovascular disease, and everybody else will be at high risk. The elderly frail patients, we put them in a different category because patients who are elderly, it's not so much the risk of cardiovascular disease that we are concerned about, but we are more concerned about the quality of life in these patient groups. And so treating them to prevent them dying from cardiovascular disease, which may occur several years down the line, is probably pointless because a lot of the medication that we use to treat these patients will be associated with side effects that can compromise their quality of life. And so we separate that group outside of the cardiovascular risk stratification. Now, into more detail, if you have a patient who is at a very high risk of cardiovascular disease, for example, those with ASCVD, atherosclerotic cardiovascular disease, what we are advising is that you do early combination therapy with metformin plus an SGLT2 inhibitor or GLP-1 receptor agonist rather than stepwise approach. Some guidelines will suggest you to go for GLP-1 receptor agonist or SGLT2 inhibitor with proven cardiovascular benefit because they don't believe that metformin has got that evidence. Well, we are advocating that in patients with type 2 diabetes, metformin has got a very good evidence base, a lot of experience with it in primary care settings, and indeed, it's a recognized glycemic control agent. So yes, we are concerned about cardiovascular disease, but we're not going to forget about diabetes. So we want to advocate early combination therapy with evidence-based cardiovascular risk factor control medications like SGLT2 inhibitors and GLP-1 receptor agonists, plus metformin from the outset. When you do that, you are actually going to intensively control your glycemia from the outset and keep it as low as possible. But in addition to that, you're also preventing cardiovascular disease, just as you would do with adding a cholesterol to these patients. We do appreciate that you will have some patients who will, for example, say, well, doctor, I don't want to have too many medications from the outset because of side effects. Or in some places, there may be issues around cost of prescribing too many medications at a go. And indeed, in some areas, there will be issues regarding concerning guidelines in various countries. And so they might not want you to consider combination therapy from the outset. If that is the case, of course, you can't go for your metformin for glycemic control, but be quick to add your SGLT2 inhibitor or GLP-1 receptor agonist proving cardiovascular benefit as second line for glycemic control, hoping that you will be preventing cardiovascular disease in addition to that. And we're advocating that you should reserve basal insulin for last and use that with caution when everything else has failed for glycemic control. How about heart failure? Again, in heart failure patients, we advocate to combine metformin plus an SGLT2 with LGLT2 inhibitor rather than doing them stepwise approach. Because if you do that, what we believe you're going to be doing is to get in good glycemic control from the outset. But in addition to that, you're controlling heart failure with your LGLT2 inhibitor. And as you know from your recent DAPA-HF trial, you don't even need to have diabetes to get benefit from an SGLT2 inhibitor. Of course, once again, if there is a concern with combination therapy and you want to do a stepwise approach as we've been used to, which we don't advocate, but if you want to do that, of course, your metformin is first line for glycemic control, but don't hesitate to add your LGLT2 inhibitor quickly to your metformin as second line, even if glycemic control is achieved. Avoid your pioglitazone and saxagliptin and use basal insulin with caution in these patients. Similar approach with chronic kidney disease, we advocate early combination therapy with metformin and SGLT2 inhibitor rather than a stepwise approach if the eGFR will permit you. Metformin as first line if the eGFR is more than 30. SGLT2 as second line if you do prefer to go stepwise, but just be careful of the eGFR target because various SGLT2 inhibitors have different eGFR targets depending on which country you are prescribing from. And then slowly add your GLP-1 receptor agonist. And remember to discontinue your GlyNice and SUs because of risk of hypoglycemia if your glycemic control is within reasonable limits. So how about your patients who are at high risk? So I have gone through the patients who are at very high risk. So the rest of the patients, we will class them as being at high risk. So this will be the rest of your patients who do not have established cardiovascular disease, they don't have kidney failure, and they are not young type 2s. So for those patients, go for your early combination therapy with metformin plus whatever you think is appropriate. Of course, if the patient is obese, you might want to add a GLP-1 receptor agonist to your metformin or LGLT2 inhibitor to your metformin rather than stepwise approach. And try to, avoid using, agents that will make you put on weight if the patient is obese. For patients with NAFLD, we advocate adding pioglitazone to your metformin from the outset. If you do want to go slowly, metformin first, and then add the rest as appropriate. Basal bolus insulin should be reserved as a last resort for patients who are failing with everything else. So I've talked about obesity. Just be careful, of pioglitazone, GlyNice and SUs, and most insulin because all insulins as they will make you put on weight. You might want to consider fixed ratio combinations of insulin and GLP-1 receptor agonists in patients with high baseline A1C at onset. With that combination, you will be needing to use less of the insulin and for that matter, reducing the chance of getting hypoglycemia and weight gain. And because you are combining with insulin, you'll be needing to use less of the GLP-1 receptor agonist from the outset and titrating slowly, thereby reducing the nausea, a side effect that is associated with GLP-1 receptor agonist. So again, in the elderly frail patients, maybe, just maybe, preventing cardiovascular disease may not be their priority. If you discuss with your patient, you might find that improving their quality of life might be their preference. And for those patients, a DPP-4 inhibitor is a safe option to use, to consider. So in summary, stepwise approach in glycemic control has not consistently led to reductions in complications as we saw in the data that I presented from our real-world evidence in Leicester Diabetes Center. Early combination therapy is safe and can reduce therapeutic inertia, and we should not shy away from, from changing our way of practicing. We have been used to the waiting to fail approach for several years, and most guidelines have advocated that. But in recent times, the guidelines are now changing slowly. The ADA EAZ consensus report also updated recently. They have also advocated initial combination therapy where appropriate. And we in Primary Care Diabetes Europe are advocating this for our patients. Patients should be categorized in different treatment phenotypes so that you can choose your combination therapy based on their various phenotypes. And the various pharmacotherapeutic suggestions for combination therapy should be considered in the different categories. Thank you very much for listening.